Hello friends, now that you are confident about the anatomy of external ear, we will be starting with the various disorders of external ear. And first of all, in this session we will be covering the congenital and traumatic disorders of external ear. We will be covering the inflammatory, neoplastic and miscellaneous disorders in the next session. Not just in ENT, it is actually better to divide any disorder into various etiologies in this manner so that you will be able to organize it, and when you are writing the exam you will be able to score better marks if you are classifying the disorders whenever a question is asked about some disorders. Okay, because if you are able to organize your thoughts into different etiology, you will be able to remember better, and when you are writing it in an organized manner you will be fetching better marks. Okay, so today I will be starting with the congenital and traumatic disorders of external ear. And yes, the first thing you will be learning is the congenital disorders of external ear. Why do these congenital disorders occur? Congenital disorders occur because there is some problem in the sequential development of the particular organ, and yes, this sequential development has to be learned in detail before we learn about the various congenital disorders, because only then we will be able to appreciate it better, isn't it? So first of all, let's learn about the development of external ear. Development of external ear I had deliberately left out when I actually taught you the anatomy of external ear. Usually it is with the anatomy that we cover the development, but here I left it out because I wanted you to correlate the congenital disorders of external ear with the development. And we will be starting with the development of the external aortic canal. And as you know, the external aortic canal is developing from the first ectodermal cleft. And what do you mean by this ectodermal cleft? We have learned that most of the structures in the head and neck are actually developing from the branchial or pharyngeal arches, isn't it? And where are these pharyngeal arches seen? During intrauterine life, they are seen in the area of the neck. And these pharyngeal arches, they appear like swellings, and it resembles the gills of a fish. As you see here, it resembles the gills of a fish, and it hence got the name branchiae. Branchiae is the Latin word for gills. And these pharyngeal arches, which are actually formed of mesoderm, it has got an external covering known as ectoderm and an internal covering known as endodermal pouch. Okay, the external covering is known as ectodermal cleft and internal covering known as endodermal pouch. So the thing that you see here, this is the ectodermal cleft. It is going inside like this. Okay, and here it is forming the external aortic canal. I will be detailing it soon. Before that, just remember that the second arch grows all over the other arches and forms, and the other ectoderms, they just regresses. Okay, only the first ectodermal cleft is left because the second arch is growing all over the other arches. Okay, and this branchial sinus is formed because this development is not occurring in a proper manner, and there is a sinus or opening left out because of that, and that results in formation of branchial sinus. This will be learning in surgery. I will be teaching you only about the developmental disorders of external ear in this session. The branchial sinus, branchial cleft, all these disorders will be dealt in general surgery. Okay, and yes, the first ectodermal cleft is the one which leads to the formation of external aortic meatus. Okay, and how does it form the external aortic meatus? Yes, this cleft is actually going inside like this, and it goes on to meet the first endodermal pouch, which is actually forming the tubotympanic recess by fusing with the second endodermal pouch. And this first and second endodermal pouch, which forms the tubotympanic recess, is the one which leads to the formation of eustachian tube and middle ear cleft. Okay, but I'll be dealing with that later on when I talk to you about the anatomy of middle ear cleft. Okay, for now let's focus on the anatomy and the development of the external aortic canal. So here, as you can see, the first ectodermal cleft is going inward and into the first endodermal pouch, and yes, it is this first ectodermal cleft that leads to the formation of EAC. But is it the whole of the first ectodermal cleft? No, only the dorsal part. Okay, only the dorsal part. Why? Because the ventral part, it simply regresses. Okay, only the dorsal part of the first ectodermal cleft leads to formation of EAC. Okay, and so that's about the development of external aortic canal. This first ectodermal cleft goes inwards and then goes on to meet the first endodermal pouch, and it is in this area the mesenchyme proliferates. Okay, mesenchyme proliferates. It is an area in between the endodermal pouch and ectodermal cleft, and initially from first ectodermal cleft only the cartilaginous EAC is formed, and so at birth along with the pinna there is the cartilaginous EAC. Pinna is formed of cartilage, isn't it? But there is no bony EAC form. Okay, it takes time for bony EAC to form. And how is this external aortic canal formed? I told you it's coming from the first ectodermal cleft, and here there is mesodermal proliferation. Similarly, the ectoderm also proliferate like this, and here a solid meatal plug is formed, and there is recanalization occurring, and this recanalization occurs in a medial to lateral direction. Okay, medial to lateral direction. That is why sometimes this external aortic canal atresia will be seen only proximally or medially, and it won't be seen distally. Okay, and yes, sorry, I told it wrong. The atresia will be seen only laterally or distally and not proximally or medially. Why? Because the recanalization is occurring in the direction from medial to lateral, isn't it? And because of this recanalization occurring in the medial to lateral direction, if the developmental arrest is occurring when the recanalization occurring in this direction like this, what happens? Only the lateral part is having an atresia. Okay, and so sometimes when you see a patient who is having an external aortic canal atresia, if you see, you won't be able to see the external aortic canal, but the external aortic canal will be developed medially. Only the lateral part will be having an atretic membrane like this. Okay, so that's about the development of external aortic canal. Now to the development of pinna. Now I told you that you have got the pharyngeal arches, and where are these pharyngeal arches seen? Pharyngeal arches are seen in the area of the neck. There are 6 pharyngeal arches and the 5th one regresses, and the pharyngeal arches have an ectodermal cleft and an endodermal pouch, isn't it? And the first ectodermal cleft is seen between the first and second pharyngeal arch, and because of that you can see that the first ectodermal cleft is leading to the development of external aortic canal, and this first ectodermal cleft is having above and below first and second pharyngeal pouch, isn't it? From these first and second pharyngeal pouch that you see here, what develops? From the first and second pharyngeal pouch develops mesodermal thickening known as hillocks of His. Okay, from the, if this is the ectodermal cleft here, around the ectodermal cleft mesodermal thickenings develop like this, and they are known as hillocks of His. Okay, hillocks of His. Now what do you mean by a hillock? Hillock is the other name for a small hill. Okay, small hill, because this thing is actually resembling a small hill around the ectodermal cleft, as you see here. Okay, it is seen as a small hill like this, isn't it? And that's why it's got the name auricular hillock. Okay, now as you can see here, these hillocks of his fuse together to form the branchial arches, and the first hillock develops from the first pharyngeal arch, and it is from this first hillock tragus develops. Okay, first hillock leads to development of tragus. Okay, in some books it is mentioned as the crest of helix also developed from the first pharyngeal arch and first hillock, but most of the books agree that the first hillock leads to formation of tragus alone, and rest of the pinna is formed from the rest of the hillocks, and it is because of the defective fusion of these hillocks the various anomalies associated with pinna develop. Okay, with pinna develop. So initially you have an ectodermal cleft, and around the ectodermal cleft you have 6 mesodermal thickenings known as hillocks of His, and they fuse and result in the formation of pinna. Okay, and one thing you have to remember, first hillock leads to development of tragus, and because of the defective fusion of these hillocks various disorders can arise. Okay, and I'll be coming to it soon. Before that, a small question for you. Pinna is made up of how many cartilages? Yes, we learned that there are 6 hillocks, right? 6 hillocks are there, and 2 pharyngeal arches are leading to formation of these 6 hillocks. So is it 2 or 6, or is it 1? Why 1? Because they are asking only about the cartilage. Okay, the same pinna cartilage is it is just continuing as the external aortic canal. So the answer should be 1, isn't it? Not 2 or 6. Okay. Now before coming to the various disorders, let's see one atavistic feature which is seen as a bump on the helix. Okay, bump on the helix. And what is this known as? This bump on the helix is something which is seen in apes as well. Okay, it is seen in apes as well. And what is it called? It is named after the great Charles Darwin. Okay, he was the one who observed this, and that's why it got the name Darwin's tubercle. Okay, Darwin's tubercle. He was the one who discovered that it is an atavistic feature which shows our ancestral origin to apes. Okay, and it is seen on the hillock as a bump. Okay, so that's about Darwin's tubercle. Now coming to the most common congenital anomaly associated with pinna, and that is nothing but preauricular sinus. Okay, preauricular sinus excision is one surgery that I am sure you might have seen when you are doing your UG. Okay, I don't know how many of you are doing your MBBS while attending this class. Yes, if you are attending your ENT OT posting, I am sure you will be having the cases of preauricular sinus for excision. And when will you do an excision for a preauricular sinus? If the patient is having multiple episodes of ear discharge from the ear, or even if it is a single episode of ear discharge, it's not ear discharge, it is actually discharge from the sinus. Okay, I'm sorry, you can call it ear discharge. The discharge is coming from the sinus. Okay, and if the patient is having such complaints, then you have to go for an excision. And why does this preauricular sinus occur? You can simply guess, isn't it? I already told you it's due to the congenital disorder of fusion, defective fusion. And what is happening here? The hillocks of His, which are the mesodermal thickenings that fuse and form the pinna, they are defectively fused. Okay, so the first and second hillock are not fused properly, and because of that in between them this preauricular sinus develops. Okay, and this preauricular sinus is typically seen in, it is a multiple time asked question, it is seen in the root of helix. Okay, it is seen in the root of helix. The preauricular sinus is seen in the root of helix. So that is the importance of knowing preauricular sinus. And this preauricular sinus, how will you excise it? Before excising the preauricular sinus, you will have to inject a dye. And what is that dye known as? It is the simple methylene blue dye that you will have to inject. And after injecting the dye, what you do is you simply trace out the whole tract and then put an elliptical incision like this. The elliptical incision is put all around the preauricular sinus, and then you dissect out the whole tract and then you remove the whole thing. Okay, so that's about preauricular sinus. Now there are some disorders, congenital disorders associated with preauricular sinus. What are they? Yes, one thing that you have to remember is the charge syndrome. Okay, charge syndrome. What is this charge syndrome? Charge syndrome consists of coloboma of eyes. Okay, coloboma of eyes, hard defects, A for atresia covani, retardation of growth, genitourinary anomalies, and finally ear anomalies. And this ear anomalies includes not just preauricular sinus, it can also be microtia. Okay, microtia. So these are the various disorders associated with external ear. And of course you also have branchiootorenal syndrome, where you will have a problem with the branchial arches, ear anomalies as well as renal disorders. And then you can have preauricular skin tract, that is also occurring due to the defective fusion of various hillocks of His of pinna.